Prophylactic use of antibiotics. We have in this table 3 columns: site, antibiotic, and alternative. Why it's important to have site? Because we have different types of bacteria which have prefer different types of our body. So cardiovascular surgery impacts on our vessels or our heart. So we must use antibiotics which can stored in these parts of the body. For cardiovascular surgery is cefazolin or cefuroxime. Alternative. Why it is important? Example, gratia penicillin allergic. So allergic is the main reason why we use alternative antibiotics. But sometimes we have some side effects which we don't want to see in this particular patient. Maybe this antibiotics is like gentamicin. It's very nephrotoxic, and our patient have chronic kidney disease, so we don't use this antibiotic for treat this patient. GI area, small intestine, non-obstructed, cefazolin. Biliary tract, open procedure, laparoscopic, high risk, cefazolin, cefotaxime, cefotetan, ceftriaxone, ampicillin, sulbactam. Biliary tract, laparoscopic, low risk, none. Appendectomy, uncomplicated, cefotaxime, cefotetan, cefazolin, any of these antibiotics, plus metronidazole. Colorectal surgery, obstructed small intestine, cefazolin of ceftriaxone plus metronidazole. Ertapenem, cefotaxime, cefotetan, ampicillin, sulbactam. Head and neck, clean, contaminated. Cefazolin of cefuroxime plus metronidazole, ampicillin, sulbactam. Neurosurgical procedures, cefazolin. Orthopedic surgery, cefazolin, ceftriaxone. Breast or hernia, cefazolin. By definition, prophylaxis is limited to the time prior to and drug the operative procedure. In the vast majority of cases, only a single dose of antibiotic is required, and only for certain types of procedures, see surgical site infections. However, patients who undergo complex, prolonged procedures in which the duration of the operation exceeds the serum drug half-life should receive an additional dose or doses of their antimicrobial agent. So, when we have a long operation and we know that the drug half-life is ended, we must inject another dose of antibiotics. Classification of antibiotics. It's not all of antibiotics, but most of it. We have different classifications, and we first of all start from chemical structure. First, beta-lactam antibiotics. Penicillins, cephalosporins, monobactams, and carbapenems. Second, aminoglycosides. Third, tetracyclines. Fourth, macrolides. Fifth, polymyxines. 6. Rifampicins. 7th, polyenes. 8th, lancosamide. 9th, glycopeptides. And 10, chloramphenicol. By the mechanism of action. First, specific inhibitors of microbial cell wall biosynthesis. All beta-lactams, you must understand. Penicillins, cephalosporins, carbapenems, glycopeptides, and monobactams. Antibiotics that violate the surface and function of microbial cell membranes, polymyxins and polyenes. Third, Antibiotics that inhibit protein synthesis at the level of microbial ribosomes, macrolides, aminoglycosides, tetracyclines, chloramphenicol, lancozamides. Fourth, RNA synthesis inhibitors at the RNA polymerase level, rifampicins. This drug used specifically to treat tuberculosis. This is antibiotics of reserve group. By the type of action of the microorganism. By the type of action of the microorganism, we have major two groups, bactericidal and bacteriostatic. Bacteriostatic means these antibiotics didn't kill the bacteria. They stop growing of the microorganism. And bactericidal antibiotics is actually kill the microorganism. So bactericidal antibiotics: penicillins, cephalosporins, aminoglycosides, rifampicins, glycopeptides, polymyxins, polyenes, carbapenem, monobactam, and bacteriostatic antibiotics: tetracyclines, macrolides, lancozamides, chloramphenicol. So it's important to choose of an antibacterial drug. When we choose an antibiotic, we should answer these questions. For what purpose we give antibiotic? First, treatment. Second, prophylaxis. First or second, what groups of pathogens do we expect to get? Where is the infections located? Some groups of pathogens looks like very specifically like anaerobic gangrene or erysipeloid. It have very distinctive looking picture, clinical picture. Where is the infection located? We must understand that most of the infection in the respiratory tract is gram-positive, and in the UTI is gram-negative. So maybe you hear respiratory fluoroquinolones or urinary tract fluoroquinolones. That is why, because we have most gram-positive or gram-negative strains. The choice of dose and route of administration of antibiotic, most commonly oral or intravenous, intramuscular, sometimes local, rectal, intraocular, topical. Dosage choice. It's very complicated question. That is why always look into the recipe. You must open your book of pharmacology and choose and see that so many different type of dosage in different types of infection. Even if you use the single one drug, it have different dosage into the different ways of use, or in different cases, or more or less severe cases of infection. So we surgeons, we must think as simple as we can. Look into the recipe all the time when you wanna use dosage choice. You shouldn't really remember all dosage of all antibiotics because it's too many. You must know indications, and you must know dosage of the antibiotics which use in your specifically clinic, because if you don't use these antibiotics, you don't need to know its dosage. Assessment of an antibiotic efficacy. The criteria for the effectiveness of antibacterial therapy are primarily clinical signs: a decrease in body temperature, a decrease in intoxication, an improvement in general condition, normalization of the leukocyte formula, and decrease in the amount of pus. The effectiveness is evaluated after 24-72 hours. Treatment does not change if there is no deterioration. In 72 hours we didn't see the health improvement, we must change an antibiotics, or our treatment will not be effective and lead to this. Duration of antibacterial therapy. It is a complicated question. You may look into the clinical recommendation. As we say earlier, you must always look to the clinical recommendation to choose dosage, because different situations need different dosation. There are 3 ways to influence the immune system. First of all, active immunization, when antigens are entered in surgery, is vaccines or toxoids. And passive immunization with sera gamma globulin insurgens, antitetanus, anticephaloccoccal gamma globulins are widely used. Immunomodulation. The use of various immune stimulants, alloy extracts, autohemotherapy, etc. methods, but the lack of a stimulating effect is that we act blindly, not on any specific immune mechanism. Along with normal ones, there are also pathological immune reactions, autoimmune aggression. So now we have the not immunostimulation and immunomodulation that is only for defective immunity. Currently, various lymphokines, interleukins, interferons, drug obtained from the thymus that affect the T population of lymphocytes are used as immunomodulators. You can also use various extracorporeal methods of immunization: ultraviolet blood transfusion, hemosorption, hyperbaric oxygenation. But you must be attentive, because most of these methods have no evidence. Mixed antisepsis is the use of several types of antisepsis. For example, primary surgical treatment of wounds, mechanical and chemical antiseptics, is supplemented with biological antiseptics, administration of tetanus serum, antibiotics, and the appointment of physiotherapy procedures, physical antiseptics. Also, an example of the mixed antisepsis can serve as peritoneal dialysis during peritonitis. Thank you for your attention. I feel sorry for my broken English. Most of the time you can read what I write, and if you have any questions, you can write it into the comments or into the LMS system. Thank you for your attention again.